and for durable control of brain metastasis. So there is a need for additional ALK TKAs that prevent the emergence of resistant subclones in untreated patients. So this is basically more looking at the CNS disease. So NCCN recommends cranial MRI with contrast as part of the initial pre-treatment evaluation unless patients are in stage 1A. ESMO also recommends CNS imaging. And the so however, in clinical practice, performing MRI for all patients may not be feasible, especially in resource-constrained settings. But I think practically in our practice, we do MRI in most patients before any radical treatment. But I just wanted to know whether you do MRI brain in a stage 4 patient. Ram?
It depends on the patient, sir. If the patient is, usually we get a PET scan done, and if there is no metastasis in the PET scan, generally we don't do MRI. But if the patient is rich and affluent, and we know that he's going to take multiple opinions, then I would generally do an MRI brain to make it complete.
Stage 4 patient, yeah, stage 4. Bhavesh?
The same, like if a patient is symptomatic or anything which hints towards kind of brain metastasis clinical symptom, then yes, we do get it done. But otherwise, as Ramesh said, that patient will invariably undergo a PET scan as an initial investigation. And if the CT scan of the PET scan is not showing any brain met and patient is asymptomatic, will not do MRI unless and until patient is having some high risk mutations like ALK.
Okay. No, but in practice, we have seen patients where PET scan has missed brain metastasis and MRI done had shown brain metastasis. But yes, practically in the stage 4 patient, routinely I don't do unless they are symptomatic. But yeah, it is if the patient questions is capable of questioning or is affording patient, definitely you should do.
I think that's the practical tip.
Yeah, practical tip. So the patient management, so we are systemic for the management of CNS disease and diagnosis. So systemic therapies, targeted therapies, ALK TKAs or ALK TKAs. Chemotherapy we use routinely. I don't think we use for brain metastasis. They may not work since they don't achieve sufficient concentration. Local therapies, whole brain radiation, stereotactic radiation, as well as surgical resection is used when the patient is mostly symptomatic. So in patients with actionable oncogenic drivers, use of CNS penetrant next generation TKS restores control of CNS disease. And management of CNS disease requires a multidisciplinary team. So to achieve maintain long-term survival, as well as to obtain local control and to minimize the negative impact of therapy on quality of life. So in a proven brain metastasis in ALK positive, so without symptoms, but if it is multiple brain metastasis, whether we will start RT or not, Ram?
If not symptomatic, I wouldn't start WBRT. Whereas if it is oligometastatic, I might consider SBRT for these patients.
In ALK positive?
Even in ALK positive, if it is oligometastatic, like 2-3 lesions which are SBRTable, then probably I'd consider SBRT and then continue the TKA.
So, but if you are not treating, local treatment, you are not planning local treatment for lung then?
No, sir. Means we will give TKA. If, for example, if the patient has multiple metastasis, because ALK positive patients have a prolonged survival, you can expect 4 to 5 years of continuation of. So whole brain RT might actually lead to neurocognitive disturbances. Whereas the patient is oligometastatic 2 or 3 lesions where you can do SRS or SBRT. I would do the SRS or SBRT. I'll start them on one of the TKIs. But not too concerned when it is only oligometastasis and if you can take stereotactic radiotherapy.
Okay. Bhavesh?
So I agree that is one of the options. If it is feasible and patient can afford that kind of therapy, that can be an option. But that has to be a limited disease, as Dr. Anand mentioned. And if it is there, you can actually get a good control of the disease and probably maybe a longer control of the disease with addition of radiation in the form of SRS or SBRT.
even in asymptomatic patients.
Even in asymptomatic patients, because these patients are, if they were not picked up on scan with a good TKI starting, they would have been under good control. But if you have started with crizotinib and patient is having asymptomatic brain met which you have not picked up on MRI, these are the patients who will come back very soon with florid brain metastasis, because it will not cover the brain metastasis. So that what I would actually agree, sir, what you are saying is that in ALK positive, it is very necessary to see whether the patient is having CNS disease or not, because the choice of TKI will accordingly change.
Yeah, I also wouldn't practice most of our patients have been on crizotinib, we would have added RT. So in lorlatinib era, we'll have to think about it. So the current international recommended guideline, NCCN guidelines, the preferred first-line treatment would be alectinib, brigatinib, lorlatinib, or ceritinib, all category 1, and crizotinib useful in certain circumstances. And stereotactic radiosurgery is recommended for limited CNS disease. So the treatment strategy, either the straight away lorlatinib and in all failure go for chemotherapy, or first line, second generation ALK TKIs like alectinib, then the second line lorlatinib, then chemotherapy. So overall, it is preferable that higher drug with the highest intracranial activity in a CNS disease should be the one which you should start with. To summarize, lorlatinib is a kinase inhibitor used for treatment of adult patients with metastatic non-small cell lung cancer with the ALK positive as detected by FDA approved test. In the first line setting, lorlatinib has the potential to manage and prevent emergence of CNS metastasis, and better understanding of prognosticators is required to help identify patients who would benefit from therapy and to inform treatment sequencing algorithms. So what would be your first line, Ram?
If a patient is affordable for third generation drug like lorlatinib, I usually get an MRI breakdown. And if there is significant CNS disease, I'd prefer lorlatinib, because it is because the first area of failure with the other drugs would be CNS. So I'd rather start with lorlatinib. Whereas if the MRI is negative, I generally don't prefer lorlatinib only because of its side effects. So generally, I'm okay with alectinib would be my first choice, and only second choice would be crizotinib, and these two are the drugs which I usually do.
So how many of your patients are in lorlatinib or on alectinib?
Alectinib, there are 2 patients, and lorlatinib, there was a patient, but right now I don't have any patient.
Okay. Bhavesh?
The lorlatinib, I don't have any patient as of now. But whatever experience sharing, whatever I have understood, it is exactly the same what Dr. Ram said, that if patient is having a CNS disease, even if asymptomatic or symptomatic, lorlatinib is the choice, and it has given the maximum survival benefit because of use of lorlatinib upfront. If not, then alectinib is the one which gives the maximum response next to lorlatinib. So lorlatinib has already surpassed the benchmark which was set by alectinib. So if we go by the best, that is lorlatinib, then comes alectinib, and then it's your choice whether you want to choose ceritinib or crizotinib depending upon the CNS disease. So I would still go for ceritinib for a CNS disease rather than crizotinib if I don't want to use radiation.
Okay. So lorlatinib is a selective ATP competitive, highly potent third generation ALK TKI with the excellent brain penetration around 75%. Improved clinical outcomes with overall and intracranial activity in patients with previously untreated ALK positive advanced non-small cell lung cancer. Upfront treatment can completely suppress or at least significantly delay on treatment, on target resistance, leading to more durable clinical benefit. This is a point summarized by both Ram and Bhavesh. So now we come to the important study, the Crown 3 trial. So as we already know, it's the stage 3B4 ALK positive non-small cell lung cancer, no previous treatment, ECOG 0 to 2, randomized to lorlatinib and crizotinib at 1:1 ratio. Stratified, sub-stratified into presence or absence of brain metastasis and Asian versus non-Asian. And primary endpoint was PFS by BICR. So the distribution characteristics are equally distributed in both the arms. If you look at this study, out of 149, almost 26% had brain mets in the lorlatinib arm and 27 in the crizotinib arm. At 18 months follow-up data, which was published earlier, so lorlatinib had a significant progression-free survival, which was not reached compared to at 18 months compared to 9.3 months for crizotinib, with the hazard ratio of 0.2, which is a very significant p-value of less than 0.001. So in an interim analysis, lorlatinib significantly prolonged the PFS compared with crizotinib with a hazard ratio for disease progression or death of 0.28. So if you see the forest plot, so almost all the subgroups all benefited from lorlatinib compared to crizotinib. The overall response rate was 76% for lorlatinib compared to 58% with crizotinib, and the median time to response, the faster response was there, but equal median duration of response was not at reach for lorlatinib compared to 11 months with crizotinib. So significantly more patients in the lorlatinib arm had an objective response compared to with the crizotinib arm. Coming to the intracranial response rate, so intracranial response rate significantly better in the lorlatinib compared to crizotinib. So there was an overall response rate of 66% compared to 20% in the crizotinib arm. Patient who had measurable or non-measurable disease, when they compared for the patient who looked at a measurable brain metastasis at baseline, the response rate was more, 82% compared to 23% in the crizotinib arm. And median time to response was equal in both the arms, while median duration of response was not reached at 18 months compared to 10.2 months in the crizotinib arm. And time to CNS progression was 16 months in crizotinib arm compared to not yet reached in the lorlatinib arm, with the hazard ratio is almost 0.07. So in the intent to treat population, time to CNS progression was significantly longer with lorlatinib than with crizotinib. The overall survival at the time of cutoff was not much difference. The overall survival was not reached in both the arms. So should we look, Ram, should we be looking at overall survival when there are significant crossover in this trial?
Yes, I think that has always been the question, sir, because are we going to use the most potent agent in the first line or keep it for later? But when we see most of the trials for the second line, the crossover generally is, for example, somebody started in crizotinib or any other, for example, geftinib. Generally, the crossover third generation or second generation TK is generally 30%. So, and we have seen from other EGFR agents like afatinib in the first line have also done very well. So it's very difficult, but generally the trend has been that you always use the most potent agent upfront so that you get the maximum best shot, because we are not sure how much of your percentage of patients would be eligible for the better TK in the second line, and that exists in our clinical world as well. So if the patient is really keen and will be able to follow up then probably you can even start with first line agent like crizotinib. We know that there are so many patients with crizotinib, they are going on years and years and doing really well as well. We can always keep the second generation, third generation for reserve. Whereas, I don't know, really, I am not sure. But generally, all the overall survival data and PFS data all seems to be favoring the third generation drugs always.
No, no, the PFS is different, grossly different. There is no question of that. So, and everybody would like to, every patient would like to have the best treatment up front. So, I think that should not be a problem. I think I'm just asking, whether we should be looking at overall survival in this trial. So, that is always a problem. So, when because of the crossover.
So just a point I wanted to mention.
Yeah.
That lorlatinib, whenever it has been used in second or third line, it has not shown a major benefit as it is showing in the first line. So even in clinical practice, whenever I have shared the experience, they said usually the patient starts progressing in 6 months, 9 months, 1 year, when it is used in second and third line, when patient has already received some kind of TKI, first or second generation TKI before. Lorlatinib does not give equally good benefit compared to the first line. So that is also one of the reason why we should use lorlatinib upfront. Probably once this data matures and reaches the median value, this curve will separate, and it will not be showing very close. The curve will separate. That's what is my feeling, and I think overall survival will be different.
No, any drug in first line will not have the same response in the third line. So that is applicable for almost all the drugs. That is not, because the overall the patient performance status, overall the disease biology also changes as they progress. Okay. So looking at the safety profile, so lorlatinib, we had grade 3, grade 4 adverse events in 72% of the patient compared to 56% patient in the crizotinib arm. Serious AS was 34% versus 27% in the crizotinib arm. Fatal adverse events were equal in both the arms, and adverse events leading to treatment discontinuation were almost equal in both the arms. So the safety profile of lorlatinib was similar to that reported in the previous studies.
So probably this is one area that's why I'm not slightly reserved in using first. Because if you look at the grade 3, 4 adverse event, clearly 72%. So that is very, means if the patient is going to have such high grade 3, grade 4 side effects for a very long, we know that it's going to work for years together. So such long time and having very high grade 3, grade 4 adverse event is generally difficult to manage, and usually the patient's willingness to continue the drug, everything. And it's a clinical trial, it's different. And in the clinical practice, if the patient has some 3, 4 side effects twice or thrice, patient stops the drug and they don't want the drug anymore.
Yeah, that is in practice, but we should look at what adverse event was grade 3 and grade 4, whether it was life remote, affecting the quality of life or not. So if you look at the adverse event, the most common adverse events with lorlatinib was hypercholesterolemia, hypertriglyceridemia, edema, increased weight, and peripheral neuropathy, and cognitive effects, compared with diarrhea, fatigue, vision disorder, nausea, which was more common in the crizotinib arm. So the difference in baseline to quality of life index, the difference mean change. If you look at it, it was better with the lorlatinib. The quality of life index change from baseline. Lorlatinib was more compared with crizotinib, and if you see the graph, lorlatinib that's better than crizotinib. So the follow-up paper, which was 36 months follow-up. So in the intention to treat population, the progression-free survival was not yet reached at 36 months compared to 9.3 months in the crizotinib arm. The hazard ratio was 0.27. And the overall response rate was 77% in lorlatinib versus 58% in the crizotinib arm. So at 36.7 months of median follow-up, so significantly longer with lorlatinib than with crizotinib. And if you see all the subgroups, presence of brain metastasis without whatever be the ethnic origin, performance status, gender, age, smoking status, and histology, all patients did better with lorlatinib compared with crizotinib. So in patient with or without baseline brain metastasis, with baseline brain metastasis, median progression-free survival was 7.2 months in the crizotinib arm, while it was not reached at 36 months for lorlatinib. So without brain metastasis, it was 11 months in the crizotinib arm, while it was not reached in lorlatinib arm. And the time to intracranial progression was 16 months in the crizotinib arm, while it was not yet reached in lorlatinib. So this is a BICR assessed intracranial time to progression patient with brain metastasis, and as already presented 7.3 months in crizotinib arm, while it was not yet reached in 36 months for lorlatinib. Patient without brain metastasis similarly said, but it's significantly better for crizotinib 13 months compared with not yet reached for lorlatinib. And if you look at lorlatinib arm, so one out of 112 patients who did not have brain metastasis at baseline, only one patient developed intracranial progression, which is a significantly important factor in our treatment, in our clinical practice. The hazard ratio is 0.02, so which is not seen in any other drug. So the overall response rate, so intention to treat population, overall response rate was 77% for lorlatinib compared with 58%. Complete response rate was around 2.7% in the lorlatinib arm. Median duration of response not reached for lorlatinib compared with 9.6 months in the crizotinib arm. In patient without brain metastasis, with brain metastasis at baseline, the intracranial overall response rate was 64% for lorlatinib compared to only 17% with crizotinib. And the intracranial response, complete response in 60% of the patients. This is a very important criteria basically. So 60% of the patients had complete response in the brain compared to only 12% with crizotinib arm. And the median duration of response was not yet reached compared to 9.4 months in crizotinib arm. Patient had at least one measurable brain metastasis. The response rate was almost 83% versus 23%, and complete response rate was 72% versus 7.7%. Adverse events. So as already discussed, Ram, so I also would feel that grade 3, grade 4 is significantly more with lorlatinib compared to crizotinib, and grade 5 toxic death is around 2 deaths in the lorlatinib arm compared to nil in the crizotinib arm. But more treatment discontinuation, permanent discontinuation arms, both the arms were equal, and dose reductions, almost more dose reduction was required in the lorlatinib arm. As already shown in the 18 months follow-up data, edema, hypercholesterolemia, hypertriglyceridemia, and increased weight gain and peripheral neuropathy, cognitive effects are more common in lorlatinib compared to crizotinib. So which new cognitive effect which we be more afraid of now?
I've seen this I've at least handled 2-3 patients with lorlatinib. All of them have some form of psychosis with lorlatinib. That is, they have some irrelevant talk and psychosis. This is very common. That is one of the main reasons I'm not very keen on starting lorlatinib. But generally, frank psychosis requiring hospitalization is very uncommon. So whatever 2-3 patients I've seen, like irrelevant talk and disorientation, etc. These are actually quite common with lorlatinib. I have very limited experience
Okay,
around
well,
2 to 3 patients.
all of us have limited experience. I don't think so. Bhavesh?
No, similar. I mean, the discussion is similar. I mean, people are not having very frank psychosis, but within 2 to 3 months, they will start showing CNS cognitive problems in the form of disorientation, even sometimes hallucinations. So those things are always in discussion. I mean, if we don't look for it, probably we'll not find it. That's what is a common thing that we have to keep that in our mind, that when the patient comes for follow-up once in a month, we have to ask patient as well as the relative that what are the changes which are specific for cognitive, because otherwise we'll miss it very easily. We think, okay, this can be because of the CNS meds which patient is already having, and we may not even consider or relate it to the longer.
So the updated Crown trial at 36 months, the efficacy and safety was maintained. Overall response rate was 77%. The hazard ratio of progression-free survival of 0.27, and AIs leading to permanent treatment discontinuation is only around 7% of the patient. Importantly, the intracranial response rates were maintained at 36 months. So that's a conclusion we have already taken. So already we have discussed that given the choice, lorlatinib would our first drug in our situation, patients particularly with brain metastasis, and in patient with minimum no brain metastasis. So we have slight still concern regarding the neurocognitive side effects. So based on that, based on the individual patient, we may be starting on lorlatinib. So the guideline recommendation for ALK rearranged positive metastatic non-small cell lung cancer, first line therapy would include alectinib, brigatinib, or lorlatinib. Others include ceritinib and crizotinib. So there's a network meta-analysis which was presented in the World Conference on Lung Cancer. So in the meta-analysis, lorlatinib was compared with almost all the other drugs in the various studies, and lorlatinib did better than most of the drugs, except for alectinib, which was slightly closer to that of lorlatinib. Lorlatinib is an effective first-line treatment for ALK-positive non-small cell lung cancer when compared to crizotinib and other next-generation ALK TKIs. And the overall survival data is immature and almost it is crossing the midline, so crossing one. So there is no statistical difference between lorlatinib and other treatments arms for overall survival. Another network meta-analysis, which showed that lorlatinib significantly improved progression-free survival compared to brigatinib. The hazard ratio was 0.57, and alectinib, the hazard ratio was 0.59 for ALK inhibitor naive patients. However, there was no significant difference was found among them in overall survival as well as the adverse event analysis. So among lorlatinib, alectinib, brigatinib, crizotinib, and crizotinib, lorlatinib has the highest probability to reach the best overall confirmed response rate, the probability of 48%, and the probability of reaching highest intracranial confirmed response rate, the probability was 44%. So both the meta-analysis has shown that lorlatinib is better than the second generation TKIs. So the first AIs we had already discussed. As Ram has said, that neurocognitive adverse event is the most likely to impact the quality of life. And so in first line ALK positive non-small cell lung cancer, how significant are the lipid profile related adverse events? Ram?
I don't think it is very significant, sir, because these patients hardly have 4 to 5 years of life. I don't think like rearranged lipid profiles is finally going to kill them. But I do monitor once in 2 months or 3 months. If the lipids are grossly rearranged, then I would consider starting them on some statins.
Bhavesh?
No, this lipid lowering agents, because the side effect profile, if we see, almost everybody will get some kind of dyslipidemia. So these are usually a part of their treatment regimen. So most of them will be on some kind of lipid lowering agent, either only statins or a combination of statins and fenofibrate. So quite common, quite common. And the good part of it is at least it is easily controllable. Not like the one which we discussed, hyperglycemia in alcoholism, which is not very easy to control. So this is quite easy to control. If we keep a watch, this comes under control usually very nicely.
So I think managing the lipid side of lipid hypercholesterolemia is easier for us with a lot of drugs available. And as already mentioned, most of them are elderly patients, and many of them already on lipid lowering agents, and most probably will have to increase the dosage. So the serum cholesterol and triglycerides testing should be performed at baseline 1 and 2 months after initiating treatment and periodically thereafter. So for most mild, moderate, and severe, we just have to modify the lipid lower, modify or start a new agent lipid lowering therapy. Only in life-threatening high cholesterol and triglycerides, we'll think about reducing the dose of lorlatinib. So by one dose level, by most probably by 25 milligrams. So a total of 20 and 24 already discussed this. So the CNS changes include changes in cognitive function, mood, and speech, generally mild in severity. These adverse events are reported a frequency of around 40%, with around 12% experiencing more than one type of CNS effect. And we should also think make note of the point that the baseline CNS metastases are present in almost 71% of this patient with CNS effects. A total of 24 patients required more than one dose modification. 15 of these patients experienced resolution and the CNS effect. The median time to resolution was around 12.5 days. A recurrence of CNS effects upon re-challenge at the same and reduced dose occurred in 6 and 7 of the patients respectively. So the guidelines for dose modification: continue at the same dosage or withhold dose until recovery to baseline. Re-challenge at the same dose or reduce the dose by one dose level. Withhold the dose until the AA is less than grade 1, and re-challenge at one reduced dose level. And if the grade is higher, permanently discontinue lorlatinib. So do you re-biopsy every ALK mutated patient at progression? Ram?
Yes, especially if I would consider, I would not re-biopsy every patient of ALK positive, because we know that certain mutations are executionally sensitive to certain drugs. But I think if you're using lorlatinib as a second-line therapy, generally doesn't matter because it has high potency that it just covers. It's the best for a second-line agent. But if you're not planning to use lorlatinib for a particular reason, then probably you should consider rebiopsy and see whether that particular mutation is sensitive, that drug is going to be sensitive to that mutation.
So if you are not going to use lorlatinib, then the option is chemotherapy, or what else is the option?
So many times I use ceritinib or alectinib also as second-line therapy.
Okay.
Reserve lorlatinib for later lines.
Bhavesh, is there whether you prefer tissue biopsy or a liquid biopsy?
So if easily doable tissue biopsy, definitely that is the first choice. But if it is not possible, or the patient is not willing. Most of the time, patients are not willing to undergo a biopsy. So in that case, we would sort out to the liquid biopsy.
One thing I want to add, unlike EGFR mutations where it is very clear how to sequence therapies, ALK is, but after first line therapy, it is very confusing. I actually don't know which drugs work well, and all this potency and etc. typing of mutation is all still experimental. We don't know whether actually this would actually translate into clinical benefit, but we have the data. And probably lorlatinib for a second line agent, I think lorlatinib is the best drug because it covers all the mutations, and without any doubt, even without getting a repapsed, then you can blindly go for a second line.
So as already we have discussed the third point. So the sequencing of TKs, we would prefer the best agent, either alectinib or lorlatinib as the first agent upfront. So resistance pattern. So our resistance to second generation TKS is largely driven by secondary ALK kinase domain mutation, particularly G1202R. And this is a mutation which is sensitive only to lorlatinib and none of the other drugs. So lorlatinib is the potent third generation ALK TKS, broad spectrum activity against ALK resistant mutations. And it is known to exhibit activity against almost all known ALK resistant mutation, including the ALK G1202R. So various mechanisms, there are a lot of mechanisms, ALK dependent and ALK independent. So as already Bhavesh has pointed out, so prior treatment reduces the progression-free survival of patients treated with lorlatinib. So second, two prior, the progression-free survival curve compared to two prior, more than two prior, more than three prior TKAs, the progression-free survival definitely comes down. And this is the seen in almost all the drugs, all the cancers and all the drugs. And they have shown that the chance of developing abnormal mutation which may not respond to further treatment is there with each line of treatment. So as Bhavesh has said, after crizotinib, ceritinib, the phase 1 lorlatinib showed only 6.9 months progression-free survival. Overall, it was around only 23 months compared with almost not reached at 36 months for first-line lorlatinib. So the drug which is closest to lorlatinib would be alectinib. So the key takeaways from today's presentation: in treatment naive ALK positive non-small cell lung cancer, compared to crizotinib in first line, lorlatinib resulted in significantly longer progression-free survival, higher overall and intracranial response rate, and improved global quality of life. The safety profile of lorlatinib was similar to that reported in previous studies. Although grade 3, grade 4 AEs were more frequent with lorlatinib than crizotinib, the majority were asymptomatic and readily managed. With sequential ALK inhibitor therapy, approximately 35% of the patient will develop compound ALK resistant mutation on lorlatinib. So the ALK G1202R resistant containing compound mutation, which may become the most common on-target resistant mechanism and probably refractory to all known ALK inhibitor. This responds only to lorlatinib. So these results support the use of lorlatinib as an effective first-line therapy for patients with advanced ALK-positive non-small cell lung cancer. So thank you. I would like to ask the company people.
One question, if you may allow. Just wanted to know the clinical experience. Ever have you tried to combine chemotherapy and ALK TKI?
No, I have not tried. Ram?
I've tried with crizotinib, especially after progression. Sometimes I've tried combining chemotherapy, and especially in situations like second line and third line where you're really not sure whether after 2-3 lines of therapy, once I've combined lorlatinib and chemotherapy, because it was a squamous cell carcinoma and it was a ALK positive tumor. So I was really not sure at that point of time. They actually tolerate well. No great. I didn't see any major adverse events with that.
Even in squamous, do you do NGS?
Yes, sir. Even in squamous, I do.
Okay.
But I don't wait for mutation testing report. But I do mutation testing even in squamous.
How many of these have been positive? Do you think average EGFR, ALK, or not?
I'd say around 10%.
10%. Bhavesh, you also do squamous.
Yes, yes, yes. We also try to do. We have started doing it even in curative setting, and we are finding patients who are having EGFR positive, ALK positive, because now it has become a mandate to do the EGFR and ALK if you want to go ahead and use the immunotherapy. So this is not only for neoadjuvant but also for adjuvant. So even in adjuvant trial where you want to use immunotherapy, they want to rule out EGFR and ALK. So it's become almost like a mandate if you want to use neoadjuvant or adjuvant immunotherapy. It is better to do the EGFR and then only go ahead.
And to add to that, some of these might actually be adenosquamous, and they might be reported as squamous cell carcinoma. That is one of the main reasons why I do even for squamous cell carcinoma.
So do you use ALK maintenance also in case of curative situation, Bhavesh?
No, there is no trial like that which is running with us, and there are trials across the globe which is running, but we are not a part of it. But I think in near future, probably if it shows a good positive result, we will try to use it. As of now, no, we don't use it. Like the Alchemist trial. So we don't know whether maintenance EGFR, maintenance ALK inhibitors like crizotinib is going to make difference or not. So as of now, no, not outside the trial. And even in metastatic setting, in fact, I had one squamous cell carcinoma lady who was both EGFR and ALK positive on IHC. So we did offer her after she progressed on chemotherapy. In second line, we did offer her combination of EGFR and ALK TKI, but her GC deteriorated very fast. We actually could not, convince the patient's husband to even start any kind of treatment.
I routinely offer ALK TKIs if the patient received chemoradiation. For surgical patients, I generally don't offer chemoradiation. I'm really not sure it is that curative. I consider that as a semi-palliative treatment. Most of the patients recur. So I generally offer some of maintenance therapy for all these patients.
No, but if for chemoradiation, the immunotherapy option is there. No, if you're in the hospital, you can afford that.
Yeah, but if it is ALK positive, I generally don't consider that immunotherapy would work in this patient. I'd rather put them on ALK direct therapy rather than immunotherapy.
So ALK maintenance following chemo. Yeah, okay.
That's true actually, sir. So we have a trial Pacific 8, which is like one step beyond Pacific trial. So the standard of arm is durvalumab, and the experimental arm is durvalumab plus domvanalimab, which is an anti-TIGIT inhibitor. So actually, they are pushing the limit of durvalumab, where we got 42% 5-year survivals with durvalumab. So now they're expecting that with this combination post CTRT maintenance, this may go even beyond 50%. So that's what is their expectation. So it is very, very strict. Even any patient who is going on to this trial, they exclude EGFR and ALK. They are not taking any patient who are positive for EGFR.
What is the drug, sir?
Domvanalimab. It is anti-TIGIT inhibitor.
Durvalumab.
Domvanalimab. These are all tongue twisters because they are just trying to find what are the resistant mechanisms for immunotherapy. Like there are many of them are going on. There are few which are showing good responses in phase 1 and phase 2 trials, even as a single agent. So that is why they are trying to combine and see whether they can cross that 50% benchmark. which is up to now, it is only 42%.
Just one will ask the company people, Santosh, which city do you sell lorlatinib more?
Chennai.
Not Chennai. I don't think Chennai will be that much. Hyderabad or Mumbai or
I
Delhi.
think Delhi, Mumbai, Hyderabad. Santosh
Yes,
can
sir.
give the correct answer.
Yes, sir. It's quite obvious, sir. Delhi being the highest in selling of lorlatinib, sir, because there is a lot of reimbursement sector, and moreover, the patient's flow is
Central
higher.
government
Yes,
minister.
sir. Yes, sir. Particularly the army is there, so they get good number of orders, and the incidence is also it's good. And comparatively, we Chennai, Tamil Nadu as a state, we also started picking up, and our business is good, sir. So, conviction of about the usage of lorlatinib in first line is becoming increased. Earlier, we used to get lots of second and third line prescriptions only. Now, slowly, the pattern of prescriptions in first line it has been increasing. We have been seeing a good number of patients, sir, and they are doing well. But as a Pfizer, usage of lorlatinib in first line, still we have a long way to go, and we don't have much of data to like the duration of therapy for the patients. So in a 6 months course of time, we will be able to know the duration of therapy for the lorlatinib patients, in particular in first line settings, sir.
The real world evidence.
Yes, sir.
Right.
And the kind of conviction you all have for usage of lorlatinib, definitely, I'm confident that it will replicate in the clinical experience, real world experience also, sir.
Okay. Okay, Santosh. Can close the meeting.
So it was a good discussion, doctor. So this was a very deep discussion right from the diagnosis and the treatment protocols which has been shared based on the clinical experiences, and also the conviction about the usage of lorlatinib in first line settings with the panelist is high, provided the AEs are less because lesser than the grade 2. And moreover, doctor, the lorlatinib giving a better efficacy and efficiency is a good choice to use in first line of patient, but requires a lot of counseling for the patients also before the initiation of the therapy. And it has been very well managed, but only thing is that the AEs has to be is a concern. But if it has been managed, definitely the patient will have a longer overall survival data as reflected in the Crown trial. So I'm pleased to thank Dr. B. Sivanation for moderating the session by spending his valuable evening. And also I thank the panelists, Dr. K. Ram Abhinav and Dr. Bhavesh Poladia for spending their precious evening, and by sharing lots of insights on the treatment protocols and management of AEs and what is the concerns they have when treating the ALK positive patients. And thanks for the new update that it has been shared that the immunotherapy, there's a lot of development is happening in the immunotherapy areas also, where the patients, particularly in metastatic NSCLC, will have a longer, good outcomes will be there. So I'm confident, doctor, that through this excellent discussion, delegates who have joined for this session will gain immense knowledge on the management of ALK positive patients with different ALK inhibitors as discussed. So I thank all delegates who have longed and made this webinar a successful one by their patients listening. So I'm looking forward for many such engagements from Dr. B. Sivanation and Dr. Ram Abhinav and Dr. Bhavesh in different platforms to share their experiences and learnings with other oncologists. So with great pleasure, doctor, we will conclude the meeting. Good night and thank you all, sir. Thank you very much, sir. Thank you very much.
Thank you.
Thank you, doctor. Thank you very much.